Yeah, I mean, what an incredible trial. In less than 1 year, in one RSV season, they were able to pull this off. This is the Rounds Table. All right, welcome back, Rounds Table listeners. John and I are recording this episode September 9th, 2025, maybe a week or two, maybe a week after the European Society Cardiology Conference, which was held in Madrid, and that ended September 1st, 2025. There were so many practice-changing randomized trials published and presented at that conference. So we thought, why don't we do a rapid fire of at least a few of those trials, more specifically 4 of those trials. John, which trial do you have up for us first?
Yeah, so first, as part of our very rapid fire episode, this study was the Increasing the Potassium Level in Patients at High Risk for Ventricular Arrhythmia by Johns et al.
Okay, and what was the research question?
They wanted to know what is the safety and efficacy of treatment-induced increases in potassium in those patients at risk for ventricular arrhythmia.
Yeah, this feels like a neat and super pragmatic question to answer. So tell us more. How did they design the study?
Yeah, this was a multi-center, open-label, randomized superiority trial done in Denmark. The patient population, they were 18 years of age and older. Patients had to have had an implantable cardioverter defibrillator or a cardiac resynchronization therapy defibrillator, so an ICD or a CRT, and they had to have a baseline potassium of 4.3 or lower. For some of the key exclusion criteria, if you had a GFR of less than 30 or if you were pregnant, you were excluded. For the intervention, patients were randomized 1-to-1 to receive treatment to increase your potassium levels versus standard of care. In the intervention group, they were given information about a high potassium diet. They were also given potassium supplements with potassium chloride tabs of 10 millimoles per liter, as well as a mineralocorticoid receptor antagonist, or both. So it could have been either the potassium supplement or the mineralocorticoid receptor antagonist. And the goal was to reach a potassium of 4.5 to 5. Additionally, if possible, thiazides and loop diuretics were reduced or discontinued in the intervention group. For the comparator, it was just standard of care. For the primary outcome, it was a composite of sustained ventricular tachycardia with a rate of more than 125 beats per minute lasting more than 30 seconds as documented on ECG or ICD, any unplanned hospitalization for more than 24 hours for arrhythmia or heart failure, or death from any cause, and the median follow-up was 40 months.
I like it. So if I have this right, open label, pragmatic clinical trial, and patients were included if the baseline of potassium 4.3 or lower. And in this intervention arm, they would get information on high potassium diet. Maybe they got potassium supplements. Maybe they also got a mineralocorticoid receptor antagonist with that goal of a sweet spot of potassium 4.5 to 5. And the comparator was just standard of care, and outcome was primarily related to VTAC or an unplanned hospitalization for arrhythmia or heart failure or death from any cause. Do I have that right?
That's it.
Okay, and what did the included patients look like?
So 1,200 patients were randomized. The average age was 62, 20% were female. Patients had an ICD for primary prevention in 43% of patients. 65% had a diagnosis of heart failure, and 50% had a diagnosis of coronary artery disease.
I feel like that kind of makes sense because we know that the biggest risk factors for VTAC are heart failure and or CAD. Okay, so what did they find?
So in the intervention group, 249 patients reached the potassium target level of 4.5 to 5. When it comes to the primary outcome, this occurred in 143 patients, or 22.7% in the high normal potassium group versus 175 or 29.2% in the standard of care group. This corresponded to a hazard ratio of 0.76 with confidence intervals ranging from 0.61 to 0.95. The number needed to treat was 12.5. There were no differences in outcomes when comparing those that did receive a mineralocorticoid receptor antagonist compared to those that did not, and the adverse events were similar between the two groups.
Okay, interesting stuff. What are some important limitations of this study?
So this study does not apply to those patients with CKD who have a GFR of less than 30. And then I guess theoretically, did patients in the interventional group who were able and encouraged to get off their thiazide and Lasix diuretics, did that improve clinicians' ability to really up-titrate their goal-directed medical therapy, which could have also impacted their clinical outcomes?
Gotcha, right. That makes sense. Stopping the furosemide, adding an SGLT2, which actually, definitely improves hard endpoints. Okay, and why was this in your top 5, or I guess really top 4?
Top 4. I mean, it's a really impressive number needed to treat. And I still remember from my first rotations as a resident on cardiology, they love keeping their potassium high. And I think this trial just really provides support for that dogma.
Yeah, I guess it sure does, especially if you have VTAC, or I guess more broadly, if you have an ICD or CRTD device. This trial suggests you should be keeping the potassium in that sort of high normal range. Okay, so 1 down, 3 to go. The trial I will be presenting is entitled Digitoxin in Patients with Heart Failure and Reduced Ejection Fraction, known as the DIGIT-HF trial.
Digitoxin, not Digoxin, correct?
Yeah, that's right. They sound the same, but they are not. Both Digitoxin and Digoxin are cardiac glycosides, both derived from that beautiful purple plant called foxglove, but different pharmacologic properties. So the drug that listeners are most familiar with is Digoxin, whereas Digitoxin, I've actually never seen it or prescribed it. I assume same for you.
Yeah, never, but it's got a great name. What was the research question here?
Can Digitoxin improve a composite of death or heart failure hospitalization in patients with heart failure and reduced ejection fraction?
All right, so what was the study design?
This is a double-blind randomized trial conducted between 2015 and 2023 in multiple centers in Europe. The population were adults age 18 plus, EF of less than 40%, NYHA of 3 or 4, and they had to be on goal-directed medical therapy for at least the prior 6 months. So, it bakes in some stability to the patient. The key exclusion, if they had a cardiovascular event in the past 2 months, if they had a heart rate less than 60, which makes sense because Digoxin and Digitoxin can lead to bradycardia, or if they had both severe liver disease and severe renal disease. The intervention was Digitoxin 0.07 milligrams once a day, so a low dose of Digitoxin. And then 6 weeks later, they would have their levels checked. And if the level was found to be outside a predefined range of 8 to 18 nanograms per milliliter, the dose was adjusted accordingly. So they could have then had their dose lowered by 0.05 or increased to 0.1 milligrams once daily. The comparator was a matching placebo. The outcome was a composite of death from any cause or hospital admission for worsening heart failure, and the patients were followed for 36 months.
Okay, who's included in this trial?
1,200 patients were randomized. The average age was 66, 20% were female. The average ejection fraction was 28%. Average GFR was 65. 97% were on a beta blocker. 40% were on an ACE. 40% were on an angiotensin receptor blocker plus a neprilysin inhibitor. 76% were on an MRA like spironolactone. And 20% were on an SGLT2 inhibitor.
Okay, and what did they find?
So that primary outcome event occurred in 39.5% in the Digitoxin group and 44.1% in the placebo group. So that's like a almost 5% absolute risk reduction in that primary event of worsening heart failure or death from any cause. Adverse events that led to treatment discontinuation occurred in 9% with the Digitoxin and 10% with placebo.
What were some of the limitations here?
So it's like 2 buckets. The first is, what's the external generalizability to this? And I say that because there was a long list of exclusion criteria, and I didn't go through all of them. So these were highly selected patients as well. They had to be on goal-directed therapy for at least 6 months. So it's even a higher selected patient. So this really should not be applying to hey, you're admitted with heart failure on the GIM ward and we're managing you right now. No. That type of patient would not have been included in the study. The other limitation is that only 20% were on an SGLT2 inhibitor. I kind of get it, just based on the time period during which the study recruited, but you would hope that nowadays in 2025, more than 80% of patients with heart failure with reduced ejection fraction are on an SGLT2.
Yeah, okay, fair points. So why was this top 4?
So 1, it's heart failure. We look after patients with heart failure all the time, and just a really neat story, because we didn't go through the details of the prior trials for Digoxin, but the prior trial for Digoxin did not show a clear benefit, which is why it isn't standard of care in this patient population, but it did show that patients with low serum digoxin levels seem to have improved outcomes. So really neat that now we have a trial for Digitoxin, which suggests it is indeed helpful.
Yeah, that kind of is cool from like a medical history perspective. You sort of forget about digoxin. We're not as familiar with for good reasons. It's not standard of care for most of our patients.
Yeah, I totally agree. And, I'm going to have to speak to my cardiology colleague / pharmacist to find out, is Digitoxin even available in Ontario, in Canada? If I wanted to prescribe it, how would I do that? Okay, 2 to go. What's up next from your end, John?
Yeah, so this one is the RSV Prefusion F vaccine for prevention of hospitalization in older adults by Layson et al.
Yes, and so the first author, Mats, I think it's pronounced Lawson. The only reason why I know that is that I've had the good pleasure of knowing Mats for 4 or 5 years now. I'm involved in his PhD committee, and he's supervised by my close friend Tor Bjering Sorensen in Denmark. So just super cool to see this trial now out in the New England Journal.
Oh, nice. Mats, well done. I did not know that. Sorry for butchering your last name.
No, that's okay. Mats is in sort of like a growing list of mentees, trainees, where I'm like, oh man, this guy's probably going to be my boss one day. Although he's in Denmark and I'm in Toronto, so who knows? But anyway, what was the research question here, John?
So the question here, what is the efficacy and safety of the RSV Prefusion F vaccine with regards to risk for hospitalization among older adults?
Okay, and what was the study design?
This was a phase 4 pragmatic open-label randomized controlled trial performed in Denmark from 2024 to 2025. The patient population, it was adults aged 60 years and older with a Danish civil registration number. There were no specific exclusion criteria unless there was any hypersensitivity to vaccine or its components, or if there was an acute illness on the day of vaccination. For the intervention, patients were randomized 1-to-1 to receive the RSV vaccine or no vaccine, and the comparator was standard of care. The primary outcome, this was hospitalization for RSV-related respiratory tract disease, and was defined as hospitalization with either a primary diagnosis code of RSV infection or a primary diagnosis of a respiratory tract disease combined with an RSV infection as a secondary diagnosis. As well, there was another component of the outcome, which was a positive RSV test performed within 7 days before or 2 days after admission.
Yeah, I mean, what an incredible trial. In less than 1 year, in one RSV season, they were able to pull this off, right? Like, this is what a high-performing healthcare system looks like. I wish we could do this in Ontario or Canada, but no, that won't happen anytime soon, but like pretty remarkable. Okay, what did the included patients look like?
Yeah, I mean, speaking to that point, so from November 18th, 2024 to December 28th, 2024, 1.4 million adults were invited to enroll, and ultimately 131,276 were included in the intention to treat analysis, with about 65,000 randomized between the two groups. The average age was 69, 50% were male, 42% had any chronic disease, and most, which was about 80%, had received the influenza vaccine during the prior season.
Yeah, it's just wild, randomizing 131,000 people over the course of a few weeks is really amazing. And they're able to do this because this is embedded in part of routine care. And then they can passively identify outcomes because of how good Danish data repositories are. Okay, and what did they find?
So the primary endpoint, which was hospitalizations for RSV-related respiratory complications, occurred in 3 participants in the RSV group, which was 0.11 events per 1,000 participant years, versus 18 participants in the control group, or 0.66 events per 1,000 participant years. The absolute rate reduction was 0.55 events per 1,000 participant years, and this corresponded to a vaccine effectiveness of 83.3%.
Yeah, pretty impressive stuff. What are a few limitations?
So I guess a couple of questions maybe related to the primary endpoint. And I think just because of how robust the Danish healthcare system seems to be, that these are probably moot points. But first, it did rely on diagnostic codes. And so I guess it might have been nice just to see a sensitivity analysis performed to get a sense for how accurate those codes are. And then second, one component of the outcome was a positive RSV test performed 7 days before or 2 days after admission. But does this correlate to being hospitalized specifically for respiratory illness, which was kind of what the authors were focusing in on? Like, what if you slipped and broke your hip? But what if you were short of breath because of RSV and that's what led you to slip and fall and break your hip? I mean, I guess the flip side of that is that if you only looked at any admission to hospital, yes, no, then you're probably going to dilute the effect of the vaccine.
Yeah, I mean, I guess that's fair. I'm not so worried about how good are these diagnostic codes because I don't think we have any reason to believe that they would be differentially worse or differentially better, right? If you didn't get the vaccine. So I'm less concerned about this. And in all honesty, up until this trial, the majority of vaccines that get approved and get used, they almost never look at hospitalization data. And instead they look at, immune mediated response, or maybe they looked at like softer endpoints, AKA the patient has the virus, but like they weren't hospitalized from it. But maybe I'm just also defensive. Okay, so why was this in your top 4, John?
Top 4, I mean, this was a monster trial. And you've already articulated like how impressive it is for a population to pull this kind of thing off. And I fully agree. Like, I think hospitalizations in older adults really matter. So I love the outcome specifically.
Yeah, totally. And it's sort of like pretty impressive reduction. Sure, the absolute event rates are low, but a single shot of a vaccine and it might prevent grandma or grandpa from being hospitalized with RSV. Sign our parents up. Okay, the last trial is entitled Apixaban for extended treatment of provoked VTE, referred to as the HiPro trial.
All right, what was the research question here?
For patients with a provoked VTE and treated for at least 3 months, is extended duration treatment with low dose Apixaban efficacious and safe?
All right. What was the study design? And also, was it done in Denmark?
Yeah, exactly. No, you took all the Denmark trials. This one was conducted in Boston, Massachusetts. So this was a industry-funded, single-center, double-blind RCT of adults with a VTE and treated for at least 3 months. They recruited from 2020 to 2023, population age 18 plus, with one provoking factor, at the time of their clot. So that might have been major surgery, trauma, immobility, or acute medical illness, which I think is a limitation, and at least one enduring risk factor for VTE. That could be like a BMI above 30, chronic lung disease, or chronic inflammatory disease. The key exclusion criteria, if they had an indication for ongoing anticoagulation, of course, they wouldn't be randomized to, placebo or low-dose Apixaban. If they had a life expectancy less than 12 months, if they had severe liver disease or severe renal disease, if they were on aspirin 81 milligrams or higher, or if they were on any dose of a P2Y12 inhibitor. The intervention was Apixaban, 2.5 milligrams BID for 12 months, and the comparator was a matching placebo. The outcome was first symptomatic recurrent VTE, and patients were followed for 1 year.
All right. What did the patients look like?
So 1,200 patients were screened, 600 were randomized. Average age was 60, 57% were female, 19% were non-white. 52% had some autoimmune disease or chronic inflammatory condition as that enduring risk factor. Almost half had a BMI above 30, so that would have been their risk factor, and 22% had chronic lung disease.
All right, what did they find?
So overall, recurrent symptomatic VTE occurred in 1% in the Apixaban group and 10% in the placebo group. So a hazard ratio probably as small as you'll ever see of 0.13. Major bleeding occurred in 1 patient in the Apixaban group and 0 in the placebo group. Fun fact, although maybe not a fun fact from the patient's standpoint, this happened because the patient was horseback riding and fell off a horse and then had a major bleeding event, but recovered. Clinically relevant non-major bleeding occurred in 5% with Apixaban compared to 2% with placebo, and that was a hazard ratio of like 2.5, albeit with wide confidence intervals that included the null. And 1 patient died in the Apixaban group and 3 patients died in the placebo group.
Geez, that is a monster response. What were some of the limitations here?
Yeah, a few important limitations. So the first is that this was a single center randomized trial, and there is a long history of single center randomized trials that show a very large effect size, and then when the study is repeated, there's no effect. The best example of that is, tight glycemic control for patients who are critically ill and in the ICU. That was a single center randomized trial, showed massive benefits of tight glycemic control, and every follow-on trial showed no benefit. So that's a really important limitation. The other important limitation is that if you had an acute medical illness, they said that is the provoking factor for the clot. I'm not sure if I totally believe that, and I wonder if maybe some of those patients who had an acute medical illness, maybe they actually had an unprovoked clot, and maybe the event rate is so much higher and there's such a large benefit because truly a subset of those patients actually had an unprovoked VTE.
Yeah, those are fair. I mean, it's such a gray zone when it comes to like acute medical illness. I'm sure it was well defined, but there's a big spectrum with regards to how ill someone could be to then invoke if it's a provoking factor or not.
Exactly. Yeah. This was in my top 4 because VTE is common and we think about it and talk about it a lot. And it challenges the current paradigm of like, if provoked, give 3 months. If unprovoked, give longer. But I'm curious to hear what the thrombosis experts who listen to our show think of this. In particular, if Eric Kaplovich is listening, I'm very curious to hear your thoughts, Eric.
Yeah, fair enough. I think there's so many of these trials. It's kind of hard to keep track of them all. Do you have a trial files for like specifically blood clot related stuff yet?
Yeah, believe it or not, we do. And listeners, that wasn't even a plug. We have a thrombosis trial files, which is, I think, our second most popular trial files.
Yeah, no surprise there.
All right, John, that is it before we end the good stuff. What do you have up on your end to discuss?
Well, I am in Calgary, but in Toronto, it's TIFF time. There's a really interesting documentary about John Candy, a pretty legendary Canadian actor. You can check out the preview for the movie. It's called John Candy, I Like Me, and it looks really good.
Yeah, I saw that I was reading the Globe and Mail or something like that. And I saw, oh, cool, a documentary. I think it's like Tom Hanks' son is a director or something like that.
Yeah, that's right. And Ryan Reynolds is involved. I think he's a producer or something.
Yeah, so Ryan, if you're listening, we're so proud of you. Keep up the great work. And thanks for supporting the Roundtable. Good stuff on my end. I guess it would be 2 weeks ago now. The I'm Pharmacy podcast is live at medicinepods.com. It's hosted by my good friend and colleague, Dr. Mina Tadros. So give that a listen. Super excited to have it as part of Medicine Pods.
Yeah, it's some really interesting content to kind of complement some of the other stuff that's hosted on medicinepods.com.
Agreed. Okay, listeners, that's it for us. Be well. And John, take care.
Okay, talk to you later, Mike. The Roundtable is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.